With a glow of the screen and a heart full of pride, he's talking with experts from the world far and wide, broadcasting his voice through the good and the grand, on YouTube, Facebook, LinkedIn, and X across the land. Every Saturday morning, he's the Urology man.
Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Glad to have you joining us. Hey, if you've been following the show, you know that for the past month, I've been doing all this from a remote location in Florida. Been spending the holidays out here in Florida, enjoying that sun and that warm weather as I get ready on Monday to travel back to our home location in Indiana, where I guess it's supposed to be warm. So from warm to warm, not too bad a deal. But anyway, I'm really going to be glad to kind of get back to my home surroundings. It's been fun, but being away for a month is kind of tough sometimes. And, you know, dealing with the makeshift studio, I've had to work with a few things that I'm not always having my full-fledged stuff that I can do. So it'll be nice to get back to the old regular studio for next week. But we got a great episode for you this week. Hey, if you're new to the show, make sure to check out our website at uronurse.com. Best place to go to learn more about the show. And it's the best place to see all of our past episodes. 179. This is episode 179. And it's also the best place to check out our audio podcast. A lot of you like to listen in your car. We're glad to do it. So check that out. So anyway, let's get on to today's episode. First of all, it's going to be a contact. You'll be able to earn a contact hour after watching. This is coming in through our cooperation with the company MyCME. And anyway, let me do a little introduction. Leonard Gomella, MD, and Grace Cullen are going to be the presenters presenting on emerging therapies in prostate cancer, key insights for urology nurses, and an in-depth educational program designed specifically for urology nurses and advanced practice providers. Participants will gain confidence in treatment selection and personalization strategies, learning how to integrate novel biomarkers with established clinical factors to support evidence-based patient centered care across the prostate cancer continuum. And remember, this presentation is eligible for one contact hour. So you'll be able to just go on our website after the show airs, and you'll be able to click that button. It'll bring you over to MyCME site, right to this program. It'll be a little pre-test you'll take, and then you'll see the program. If it makes you watch it, you don't have to watch, just skip to the end. It'll bring you to the next button, and then you'll be able to fill out the post and get your free contact hour. Not bad. So let's start our show. Let's start our show now.
These are the objectives for the talk. I'll let you guys read that. All right. I will go ahead and call up Dr. Gomella now to get started.
Great. Well, good morning, everybody. Happy to be here. Thanks to SUNA for the opportunity. Also, my wife and I spent 10 years in Lexington, so this is sort of coming back home for us a little bit. And I, again, want to thank Plexus and the sponsors for letting us be here today. So we're going to have a tag team between myself and Grace. I represent the urology side. Grace represents medical oncology. So I think it's going to be a good balance to present everyone with all the great things going on with advanced prostate cancer. So again, everybody in the room knows this well, that prostate cancer is the leading solid tumor in men in the United States, but it is the second leading cause of death behind lung cancer. And interesting data that's been happening over the last couple of years. We had seen a steady decline in the death rate from prostate cancer. And then, as you all know, about 5 or 6 years ago, the national group made some recommendations against screening for prostate cancer. And as you know, the way prostate cancer works, it takes a couple of years before you really see an impact what's going on. But the problem that we had was not recommending screening for prostate cancer as some guidelines that came out a couple of years ago. We believe is part of the reason that we have seen actually a increase in the incidence of deaths from prostate cancer. So something we're going to have to just keep an eye on. You all know there's a lot of political background to screening for prostate cancer because it's such a common cancer. So again, a little bit about prostate cancer facts. Tends to occur more in men over the age of 40 to 50. We still do not know the cause of prostate cancer. We know what makes aggressive prostate cancer, and that is things like COXB13, BRCA1, BRCA2, mutated genes that we'll talk a little bit about. But again, they do not cause prostate cancer. But if you get prostate cancer and you happen to have one of those mutations, it tends to be a little bit more aggressive. And again, there's growing implications that both smoking and Agent Orange exposure may be a reason for increasing the risk of prostate cancer. However, the good news is that literally when we diagnose localized prostate cancer, the 5-year survival approaches 100% because when it's localized, it's a very treatable disease. Cure is highly likely, but we never guarantee that because we follow men long-term with PSA. But as you all know, active surveillance has become a standard over the last 5 to 10 years of men who do not have aggressive high-risk prostate cancer. And that's been a big breakthrough for a lot of what we do in prostate cancer and actually sort of addressed a little bit of the controversy about screening for prostate cancer and overtreating clinically unimportant prostate cancer. But what we're going to talk about today is kind of the problem. The problem is metastatic prostate cancer. Once it gets outside of the prostate, we can maybe send it into remission, but cure is currently not possible today. And something that we deal with prostate cancer, and if you think about it, think about every tumor that we have in both men and women. Prostate cancer is multifocal. There's usually not one cancer in the prostate, but if you take the prostate out and look at it, you'll find multifocal disease. And this is one of the challenges that we have in dealing with prostate cancer. Sometimes we'll find the main prostate tumor, but very often there'll be smaller tumors spread through all outside the prostate. And what this leads to is the challenge of individualizing care in prostate cancer. And again, we made a lot of progress, and we're going to talk today about some of the great progress we made, particularly in the treatment of advanced disease. So why is a urologist talking to a group of nursing staff on the management of prostate cancer? Well, for the last 100 years, it seems like, since the last century, we've been doing multidisciplinary clinics at Jefferson and Thomas Jefferson University. Those of you that have been around a while know that back in the 1990s, it was sort of like the Hatfields and McCoys when you talk to radiation oncologists and medical oncologists and urologists about how to treat prostate cancer. So we've been together now. All the new patients come in, get a multidisciplinary evaluation, and then we decide who's the best discipline and what's the best approach for the patient. So we've actually been able to show in several publications treating patients and approaching patients this way actually improves the long-term outcome of their care. So here's a quick overview of the clinical states of prostate cancer. Again, when we mention localized disease, most of the time we do pretty well, but there are patients after treatment with radical prostatectomy or radiation have PSA recurrence, and then it can go on different pathways. And these 4 boxes over here are the ones that we're going to really talk about, and that is really recurrent prostate cancer, rising PSA after definitive treatment, or a patient who presents de novo with a rising PSA and metastatic disease. So here's the 4 different areas: non-metastatic castrate sensitive, metastatic castrate sensitive, non-metastatic castrate resistant, and then finally the big one that gives us the most fear is really the last one. That's metastatic castrate resistant prostate cancer, and sadly, that's the one that causes mortality in our men with advanced disease. So the important thing for us in our discussion this morning is the identification of metastatic disease, and clearly localized versus metastatic disease is the first big break point when you come to the diagnosis of prostate cancer. PSA gets a lot of negative press when it comes to screening for prostate cancer, but when it's used appropriately, it's a pretty powerful tool. What is undeniable is the fact that PSA is the best tumor marker of any solid malignancy anywhere. There is no tumor marker that is better than PSA when it comes to detection of recurrent disease and recurrent prostate cancer. So again, we're going to be talking a lot today about advanced prostate cancer. But one of the big things that has come down the pike the last 2 or 3 years is PSMA PET. And PSMA PET, I think, has been one of the most revolutionary aspects that we have in detecting advanced prostate cancer. And I think you all know how important that it is, because we can now, after, let's say, radical prostatectomy, even at a PSA level of something like 0.5 or 1.0, standard imaging might not pick up a metastatic lesion, but at a high likelihood that a PSMA scan is going to pick that up. So a lot of the things we're going to talk about, PSMA has not worked its way yet into, it's worked its way into current clinical trials, but a lot of the clinical trials that we're going to talk about that determine our approach to prostate cancer did not have PSMA involved. And now PSMA scanning is going to be a part of all of our clinical trials that look at advanced prostate cancer. Everything that we're going to talk about today, the foundation of advanced prostate cancer is androgen deprivation therapy. And that is the foundation, whether you're adding on an androgen receptor pathway blocker, a PARP inhibitor, lutetium, or whatever it might be. ADT, keeping the testosterone down as low as possible, is really a foundation. And everyone knows that the goal is to keep the testosterone level less than 50. Ideally, most clinical studies show outcomes are best when you can get that testosterone down to less than 20 nanograms per deciliter. And again, you all know many different approaches today, agonist, antagonist, but one of the new drugs we have is the Regulolix, which is an oral agent, which a lot of patients have really taken a liking to, as opposed to coming in and having periodic injections. So here's kind of a timeline for some of the FDA-approved agents. If you look into the last century, before 2000, we really had very little from a medical oncology standpoint. And in fact, most of those drugs today really are not even used anymore. The big breakthrough in advanced prostate cancer came in the early 2000s when docetaxel was discovered to extend survival in several major clinical trials, both in Europe and in the United States. And then it's almost like in 2010, somebody shot a starter pistol, because from 2010 until today, there was just amazing progression of new treatments for advanced prostate cancer. And I know we're going to talk a lot about those this morning, from abiraterone, enzalutamide, all the way through the PARP inhibitors and lutetium. So again, a lot going on. It was very quiet for a long time. In fact, medical oncology had very little role in the management of advanced prostate cancer, mostly palliative care before 2000. But today, medical oncology really has a very prominent role in the management of metastatic castrate-resistant prostate cancer. So these are just some of the general characteristics, and we'll keep coming back to this concept over and over again. We have the androgen receptor pathway blockers. We have Sipuleucel T, which is still out there. It's not used as much as it used to be, but again, it is still available. We have cytotoxic chemotherapy. We have DNA damage pathways with radium-223, which is out there. It's not used, again, as much as it used to be, but it is still a viable agent. And of course, when you get all the way over to the right, you really get involved in what I call precision medicine, or the biomarker treatment of advanced prostate cancer. And that's really defining what we do today in advanced prostate cancer. We used to sort of just try something and see if it worked. Today, we are very focused on precision medicine using biomarker directed therapy. So what we're going to do is talk about some of the key clinical trials and treatment of, first we're going to talk about non-metastatic castrate-sensitive prostate cancer. And what is that? That's the patient who's had definitive treatment for localized prostate cancer, either radiation or surgery, but what happens is their PSA starts to go up. The definition after radical prostatectomy is a PSA of 0.2 and rising. The definition after radiation therapy for progression is what's known as the Phoenix definition, and that's a nadir plus 2. So you take the lowest PSA, and then as someone's PSA goes up by 2.0, that is called recurrent, radiorecurrent prostate cancer. So how do we monitor patients, follow local therapy? Again, PSA, as we mentioned, is absolutely the best tumor marker today. Very often standard imaging won't pick up a lesion or a spot with metastatic cancer, but standard imaging is CAT scan, MRI. Today, PSMA is kind of rewriting that whole pathway, and we believe that we're discovering patients with metastatic prostate cancer much earlier than we ever did before. And again, the key levels, as we mentioned, 0.2 and rising for recurrence after radical prostatectomy. And again, the Phoenix definition is the nadir plus 2. So what are our options? So after radical prostatectomy, it's usually radiation or just simply androgen deprivation therapy. Is usually what's most commonly done. After radiation, some men undergo salvage prostatectomy. I will tell you that we tend not to like to do that because of the complication rate. Cryotherapy and, of course, HIFU, focal localized therapy, provided you can prove that the patient only has localized prostate cancer. These are options. But ADT is always considered in the paradigm for patients who have recurrent prostate cancer with a rising PSA after local treatment. So when you think about ADT, it doesn't mean we have to treat everybody. There are many men who can go for years and years and years with a slowly rising PSA who really are not manifesting any symptoms. So what do we look at before we make that decision that we're going to go full in and put a man on androgen deprivation therapy? So life expectancy greater than 10 years, a rapid PSA doubling time, high-grade aggressive cancer of greater than 8. If the biochemical recurrence occurs within 2 to 3 years of either radical prostatectomy or radiation, that's an ominous sign that this patient is going to have aggressive prostate cancer. And again, it still is a little bit debated if early intervention with androgen deprivation extends survival. We only have one trial out there called the TOAD trial, which is actually run in New Zealand and Australia, that basically showed a little bit of improvement if you use early androgen deprivation for a post-localized treatment recurrence. It helps a little bit, but again, a lot of this is a sort of mano-a-mano decision between you and the patient to see exactly what their interests are, because again, ADT is associated with side effects. One of the things we always focus on is PSA doubling time, and we'll come back to this a little bit later. PSA doubling times less than 6 to 9 months are ominous for an early recurrence. If someone has a very long PSA doubling time, greater than 10 to 15 months, the aggressive need to put that man on androgen deprivation therapy may not be there. They may want to be put on androgens, you may feel better, but again, PSA doubling time gives us a very good future look at the chance that this patient is going to develop symptomatic metastatic disease, because most of these men with these early PSA recurrence are completely asymptomatic. Do you want to put a man on androgen deprivation therapy who's completely asymptomatic and cause all of the side effects of ADT? Again, ADT is a tremendous treatment, but again, not without side effect. What about post-radiation therapy risk for developing metastasis? Again, if you look, the patients who are treated with radiation who have very high Gleason score, who have locally advanced disease, and have a rapid PSA doubling time, those men are at risk for developing metastatic disease, and you may want to consider early use of androgen deprivation therapy. Now, intermittent androgen therapy is something that a lot of us do. I'm sure a lot of you are involved with that. Intermittent therapy is actually just as good as continuous androgen deprivation therapy. Intermittent therapy, as you know, is where you put someone on hormones for 12 to 18 months, then you stop it and follow the PSA. Again, this study that was done several years ago really showed that continuous androgen deprivation, and again, I want to point out to you at the bottom there on the x-axis, we're talking 10 to 12 years. So again, we can really extend or delay the treatment for a lot of these men with the side effects of androgen deprivation therapy if we take an intermittent androgen deprivation therapy approach. Again, a lot of controversy about that, but I will tell you, I use that a lot in our practice, particularly for older gentlemen who are having just a PSA recurrence and who are asymptomatic. Major study came out over the last year known as the EMBARK trial. And the EMBARK trial really is very mature data. And essentially, it looked at men with high-risk features of prostate cancer, mainly after radical prostatectomy, and who had an elevated PSA following their radical prostatectomy, and they were randomized to enzalutamide plus leuprolide, placebo plus leuprolide, and then enzalutamide alone. And this has very long-term data. Again, the metastasis-free survival was significantly improved in men who had enzalutamide and LHRH analog. So again, something to think about. Now, long-term use of these drugs, we have to be sensitive to, but when you see progression-free survival looking this impressive, going out this many years, it's something you have to think about adding enzalutamide to your androgen deprivation therapy in men with high-risk disease. Another trial that was recently reported was known as the PRESTO study. Everybody has to have a cute little name for their study. You know, it used to be, RTRG 9107 or SWOG 3205. Today, everybody has a name. This one's the PRESTO trial, and this looked at apalutamide plus ATT. And again, it showed a fairly similar improvement in progression-free survival, combining the androgen deprivation with the apalutamide. So next up, I have Grace, who's going to run us through a couple of patient scenarios to kind of put a framework on what we've been talking about.
So we're going to try to apply what we heard and learned so far from Dr. Gomella with our first case, that of Mr. Smith. He is a 72-year-old male, previously received radical prostatectomy followed by salvage RT. Prior medical history includes hypertension and hypothyroidism. His PSA has been increasing and is currently at 8.8 with a 9-month doubling time. His PSMA PET scan showed no significant uptake. So what we know about the medications that we tend to use, the hormonal therapy that we use for prostate cancer, is that there is an associated cardiovascular risk with these agents. It's not very high, but it's present. And there's also a risk for thromboembolic events. This is actually the most common cause of death among the prostate cancer population, especially in the setting of non-metastatic disease. So like Dr. Gomella said, you have to be careful on your choice of who to treat and when to treat. Good control of blood pressure is very important, and other risk factors that you might want to weigh into when you're trying to reach that target goal is their age and comorbid conditions. So for high-risk patients with underlying cardiovascular risk, you probably want to try to shoot for systolic between 120 to 130 and diastolic under 80. And for lower-risk individuals, 125 to 139 will be your systolic goal. Other comorbid conditions need to be under good control, such as your hyperlipidemia, diabetes, and if they're smoking, cessation counseling is very important too. And make sure you're working with other subspecialties like cardiology and definitely primary care. Aspirin low dose can also be considered for patients with underlying cardiovascular risk, obviously unless it's contraindicated. And you might also consider ECG monitoring because enzalutamide, for certain agents, particularly enzalutamide, it has been associated with prolonged QT intervals. Other things to consider when starting patients on medications in terms of adverse events is their skeletal health. Androgen deprivation has been associated with loss of bone density. So we try to do screening at baseline before you start the treatment and at least every 2 years during the course of treatment. Smoking cessation, once again, because smoking has been proven to be associated with an increased likelihood of loss of bone density as well as the use of alcohol and caffeine. We try to prophylactically use calcium with vitamin D supplements for some patients too on a daily basis. And weight-bearing exercises has also been proven to minimize the risk of loss of bone density, so we encourage that among patients. In terms of fracture prevention, if patients are found to have osteoporosis or using the FRAX tool calculator, they're found to be at high risk for fractures, we might consider prophylactic agents such as osteoclast inhibitors, biphosphonates, and denosumab. Osteoclast inhibitors decreases bone turnover and increases bone density. Very important to also note, quality of life is very important. Like Dr. Gomella say, you want to weigh your risk and benefits. Not everybody who can be treated should be treated. These agents are associated with a high likelihood of fatigue. Up to 77% of patients might develop a certain degree of fatigue. So what I recommend for patients is regular exercises. Exercise has actually been proven to be superior to medications in combating fatigue. Balanced diet, and consider dose reductions if it's really persistent. Erectile dysfunction can happen also. Use of medications such as PDE5 inhibitors, for example, sildenafil can be considered. Be careful using these agents. The nitric oxide component of these medications can induce vasodilation and lead to hypotension. We know prostate cancer tends to be a disease of the elder males, for the most part. So maintaining that blood pressure within levels that are safe for them is also crucial. Vacuum-assisted devices can be considered for use also, as well as penile injection of alprostadil. A lot of patients kind of get turned off by that though, but that can also be considered. As far as hot flashes, also very common. I would say in my practice, this is the most common. Up to 80% of patients will complain of this. This is a result of decrease in some of the sex hormones and an increase of norepinephrine, leading to poor peripheral vasodilation and regulation of the hypothalamus. And I know there's a lot of medications that can be tried for this, but I've had a patient actually try 2 or 3 of them, nothing worked, and he was able to get online a device he wears around his neck that is battery operated and has little fans that gives off cool air constantly, and he swears by it. Other strategies for managing adverse effects of medications used for non-metastatic castrate-resistant prostate cancer, including hot flashes, will be the use of estrogen and these medications. But you want to be careful too, because they themselves also cause adverse effects such as fatigue, gynecomastia. They can be toxic to the liver and can cause increases in lipid levels as well. Progestin can be considered. MEG-ACE can be considered. It can lead to weight gain, so make sure that you're educating your patients on that. SNRI can be considered also, such as venlafaxine, and we typically start this at a lower dose. This is commonly used for depression as well. So for use in hot flashes, we usually use it at 37.5, but you can titrate up to 75 milligrams, but give it time, at least 1 to 2 weeks in between titration. GABA analogs can be considered. They're involved in neurotransmission and nociception, such as gabapentin, and you can use a max dose of 900 milligrams daily up to, or distributed over a course of 3 times daily dosing of 300. I would go low and slow with this medication. It can induce drowsiness. So I usually will start patients anywhere from 100 to 300 milligrams daily and see how they do. Endocrinopathies can be found with the use of these agents too. It has been associated with increase in blood glucose levels. So if you have a patient with underlying diabetes, make sure that you're reaching out to their primary care providers to let them know I'm about to start this patient and this agent. I can impact the diabetes that you are managing, so work hand in hand with primary care. Apalutamide has been associated with up to a 6 to 8% risk of hypothyroidism, so replacement therapy such as the use of levothyroxine might need to be considered. And obviously, when you intensify treatment, we are now entering the era of not just monotherapy. A lot of the studies are now finding superiority in doublet and triplet regimens. When you are increasing the use of agents in a patient, then you're thereby increasing the chances of adverse events too. So be mindful of that, and shared decision-making between you and the patient is very important. Like Dr. Gomella said, consider the use of intermittent treatment whenever possible. That minimizes the risk of adverse effects and also resistance later on during the course of the disease. Typically for patients who are castrate sensitive, non-metastatic, who has had radical prostatectomy, if you're giving them a break, you might want to consider resuming after reaching levels of 2 or higher. And if they've had no radical prostatectomy, only radiation, you might have some more flexibility to go a little higher at 5. In the EMBARK trial, using enzalutamide, they actually found that up to 90% of patients were able to tolerate a break of about a year and a half. So back to our case of Mr. Smith. Now he wants to start treatment after a discussion with him. Which would be your best agent to use to add to his ADT? Will it be darolutamide, enzalutamide, apalutamide, or docetaxel? That is the correct answer. Reason for that is because he has hypothyroidism. If you remember a few slides back, apalutamide is associated with hypothyroidism. So if you already have a problem with that, you don't want to aggravate it. And darolutamide and docetaxel is approved in the setting of metastatic disease. All right, well, we're going to move on to the next topic Dr. Gomella is going to talk about.
Thanks, Grace. Yeah, that gives a great platform for everything that we're going to talk about with androgen deprivation therapy as the basis. So next we're going to talk about the next category is metastatic castrate-sensitive prostate cancer. These are men who really typically not been screened for prostate cancer. Their primary care doctor maybe is not a believer in screening for prostate cancer. And they just come in with back pain, and lo and behold, they are found to have an elevated PSA. And using standard imaging, we find evidence of metastatic disease. Again, the difference between the first category and the second category is the MCSPC. That means that standard imaging has identified a lesion. So again, our advances that we have over the last 10 to 15 years have been extraordinarily thanks to basic science research, but also due to innumerable well-done clinical trials. And you see a whole bunch of clinical trials here, but we're going to focus more on the more recent clinical trials in this particular area. So again, we talked about metastatic castrate-sensitive prostate cancer. ADT is the platform. And again, your choice of an agonist, an antagonist, a shot, a pill is up to you and the patient. I don't think I've seen orchiectomy used probably for about 10 years. But again, it does really rely on very selected patients when it comes to some compliance issues and the like, but very infrequently done today. And again, intermittent therapy is something we've talked a lot about. There is old data on flutamide and oral anti-androgen monotherapy. Again, it is done. There's some trials out there using 150 milligrams of Casodex, but again, not commonly done today because many of our drugs that we have out there are much more prominent. A big thing now is the addition of a second agent. So ADT plus a second agent. Again, bicalutamide and the flutamide and the older drugs were not used that much, but we're talking about now androgen receptor pathway blockers primarily. If you look at the advances in metastatic castrate-sensitive prostate cancer, again, second agents used, I think, very commonly, apalutamide, enzalutamide, or darolutamide. You can add abiraterone. Chemotherapy is an option, and for some patients, It may be the most cost-effective option because a lot of infusion, as you all know, using chemotherapy is covered by insurance companies. Some of the oral agents gets a little fussier, but again, it remains an option for these men. No question that if they have high volume disease versus low volume disease, that using more aggressive therapy is probably appropriate. Again, we have a lot of clinical trials that are out there, and you're familiar with some of the names: Latitude, Stampede, Peace, Enzamet, and the like. But again, if you look at high volume versus low volume, and again, this is an important differentiator. In general, high volume disease of these men with metastatic castrate-sensitive prostate cancer is usually more than 4 METs that you can actually count on standard imaging. Low volume disease is less than that. And again, you have all these options, all these reported clinical trials that are out there. For low volume disease, low risk disease, again, you can use a little bit less aggressive therapy to treat these men because their overall survival is better than men with high volume disease. So again, we have level 1 evidence not only for reducing progression, reducing the evidence of new METs, but actually for overall survival. So again, all these studies, all the interventions that you see here, including one small subset in the Stampede group where they use localized prostate radiation. Because remember, these are patients who are presenting de novo. They've never had any treatment. So there is some suggestion that actually treating the local lesion with radiation and then with hormone therapy, with or without chemotherapy, is beneficial. But again, if you look at the benefits in the risk groups, most of them have benefit, whether or not it's a low risk group, low number of METs, or a high risk group. And again, we have some newer studies out there, the Amplitude trial and the like, that have not been reported yet. A lot of clinical trials are out there. It's almost difficult to keep up with all the clinical trials. What I find most useful is when a trial gets reported, if it gets incorporated into NCCN guidelines, that's most helpful. If it's in the guidelines, that gives us the best pathway forward. But again, we're even using now the lutetium for metastatic, newly diagnosed castrate-sensitive prostate cancer. So again, a lot of clinical trials are out there. This is the NCCN guidelines. Actually, there is a 2026 upgrade that's out there. And again, I find this is the most useful thing. We actually have these posted in our practice office for the students and the residents, and we refer to these things very, very frequently. And again, this is low volume castrate-sensitive prostate cancer. Again, when you work them up for metastasis, you decide if they have low volume or high volume disease. So very important to differentiate: higher volume, more aggressive; low volume, less aggressive. So we have another patient that we could talk about here, and Grace will talk about some of the side effect profiles of the agents that we use commonly in metastatic castrate-sensitive prostate cancer.
So these are the androgen receptor pathway inhibitors that we typically use in managing these types of patients. We have the choices of abiraterone, enzalutamide, apalutamide, darolutamide, and also the chemotherapy option of docetaxel. So again, quite common cardiovascular and fatigue for these patients. What's unique to abiraterone is that it is associated with hypokalemia. It's not very common, but it can happen. And also adrenal insufficiency. And so when we start patients on abiraterone, we always have to put these patients on prednisone prophylactically too. And you can dose it between 5 to 10 milligrams daily. And then with enzalutamide and apalutamide, it's been associated with seizures. It's a small risk, but a risk nevertheless. So if you have patients with underlying seizures, underlying neurologic conditions such as traumatic brain injury, where their threshold for seizures would be quite low, probably not the best agents to use. Darolutamide can be considered. It doesn't cross the blood-brain barrier, so less likely to induce seizure for that population. For enzalutamide and apalutamide, it can have a tendency to interact with your anticoagulants and proton pump inhibitors. So it can minimize the potential of these medications, so be careful when using them for these patients. And again, apalutamide has been associated with hypothyroidism, so supplementation might be necessary if you cannot avoid using the drug. And for all of these medications, all of these RPs, you can consider dose reduction if symptoms are persistent. For docetaxel, it has been associated with hematologic adverse events. And usually your grade 3 to 4s, these are the times or grades that you have to actually treat patients. Grade 3 anemia will be hemoglobin of less than 8, which, sometimes might require management. Not always. We might have a threshold of maybe transfusing at levels of 7s for some patients, but typically at levels of grade 3 to 4, you are treating the patient and perhaps holding the dose until you go back to a grade 1, which is a hemoglobin of 10 or above. And typically grade 3 to 4 reactions would happen in the first cycle. It can still happen later, but most commonly at that degree, by the first cycle, you know how hard this drug might be for your patient. It has also been associated with GI problems such as nausea and diarrhea, fatigue, and peripheral neuropathy. So be very careful if you are putting a patient with underlying diabetic neuropathy on this medication. You can potentially aggravate that, and quality of life is very, very important. So we're going to move on to our second case, that of Mr. Jones. He's a 75-year-old male who was diagnosed with low-volume metastatic castrate-sensitive prostate cancer. His medications are currently hydrochlorothiazide being used for his hypertension and gabapentin for his diabetic neuropathy. He's about to start on androgen deprivation combined with abiraterone and prednisone. What blood test should the APN monitor while he is on this regimen? Is it his basic metabolic panel, his LDH, his SPEP, or his AFP? BMP is right. LDH, SPEP, and AFP are tests typically used for other conditions. You're going to do a BMP again because the patient is about to start on ABI, which has been associated with hypokalemia, so you want to monitor his serum potassium levels. All right, we're going to move on to the next topic.
Now we're going to move to a category that actually we didn't have too much to do until a couple of years ago, and that's non-metastatic castrate-resistant prostate cancer. Which category is this? These are the men who've been treated with androgen deprivation therapy after they've had a local failure. They have castrate levels of testosterone, but the PSA starts going up. So until a couple of years ago, we kind of didn't know what to do with these men. We used to image them. We used to think about early versus late hormone therapy. But some very important clinical trials came out a couple of years ago that gave us definite phase 1, level 1 evidence how to treat these men. So if you have non-metastatic castrate-resistant prostate cancer, PSA doubling time is one of the major factors to decide if the man is going to ultimately develop measurable metastatic disease and ultimately die from prostate cancer. We know that if you can delay the development of skeletal-related metastasis, that the man's overall quality of life and his overall survival are greatly improved. And this is one of those accepted concepts, is the PSA doubling time. If a man has a very rapid PSA doubling time, less than 3 to 6 months, his chance of developing obvious metastatic skeletal and painful disease is quite high. But if that is a longer PSA doubling time, greater than 9 to 15 months, the chance that they're going to develop symptomatic skeletal-related events is pretty small. Very important because this gives you a decision: early versus late androgen deprivation, intermittent versus continuous. However, what this work did was, this clinical state provided us with were 3 pivotal trials known as the Spartan, Prosper, and Aramis trial that led to FDA approval of these agents for non-metastatic castrate-resistant prostate cancer. So we now have good evidence that we have oral agents to add on to androgen deprivation therapy in these men. Now, the big behind the curtain question is, will this category continue to exist with PSMA scans? So again, remember, standard imaging in these men who have castrate-resistant non-metastatic prostate cancer, you couldn't see the mets on MRI or CAT scan. With PSMA, we're picking these mets up earlier. So our field is undergoing a little bit of questioning. Will this disease category continue into the future? Nonetheless, we have 3 clinical trials out there using enzalutamide, apalutamide, or darolutamide along with ATT. And again, if you look at the trials, they're all pretty good. Metastasis-free survival is increased by about at least 15 to 20 months in all 3 studies. So again, significant improvement. And as Grace mentioned, always remember the adverse side effect profile. It's just not a matter of giving someone a pill anymore. So if you look at the T&M classification, it's M0 disease. So again, this is from the NCCN guidelines. The big break point is PSA doubling time. Hopefully you'll have a couple of PSAs. These men have been on ADT, they've been followed, and then you can get the differentiation. Hey, is this a bad actor who has a quick doubling time or someone who maybe has a much slower doubling time? So again, a lot of this is also patient discussion with the man about what their plan is, what their overall health is, and again, what's their level of anxiety. We tell a lot of patients, PSA is just a number sometimes, and then we turn around to say to them, well, your PSA is not looking good. So you got to really work with the patients, and particularly in this particular disease state that we have. Lastly, we're going to come to the big dog, I call it. This is the problem that we have. And when I say this is the problem, this is why men die from prostate cancer. They die from metastatic castrate-resistant prostate cancer. No matter what we throw at the prostate cancer, it continues to progress, causes all sorts of problems with quality of life, as well as affecting overall survival. This is a great slide. I mean, this slide really tells you where we have been with metastatic castrate-resistant cancer. Monotherapy is an option for these men in addition to androgen deprivation therapy. Biomarker-driven, that we'll talk a little bit more about PARP inhibitors. PSMA is actually a biomarker for lutetium. And lastly, one of the big advances that we've seen in the last 3 years has been the combination therapy, doing doublet. Doublet, as you all know, is the ADT plus an oral agent. We're now into triplets, where you do ADT, an oral androgen receptor pathway blocker, and a PARP inhibitor. So this is a hot area right now. Triplet therapy is very common in other cancers like breast cancer, lymphomas, and things like that. This triplet therapy for us in advanced prostate cancer is being done based on very effective clinical trials. If you look at the historic data, looking at the medications that we've spoken about earlier, CYP-T, enzalutamide, docetaxel, we have really only nudged the advanced survival data by 3 to 4 months in many, many cases. We now have much more prominent overall survival, not just progression-free survival, but overall survival using some of our triplet therapies. So, you may be familiar, those of you who have been in the prostate cancer world for a couple of years, abiraterone versus enzalutamide versus abiraterone. There used to be a lot of switching back and forth. If a man had metastatic castrate-resistant prostate cancer and wasn't responding to Abi, you put him on Enza versus Abi. Pretty much today, the abiraterone followed by Enza is probably a better strategy. If you have Enza and then put them on abiraterone, tends not to work as well. Something that we tend to forget about is chemotherapy. Cabazitaxel's out there as a very effective agent to deal with these men, and there are some very novel studies out there combining immunotherapy with chemotherapy in these patients. And of course, one of the big areas right now is lutetium-177, which I think is going to be, in the next 5 years, the next revolutionary step, because it's actually now being used with radical prostatectomy. and having amazing results and called the lutectomy trial. So again, this is something to really keep your eyes on. But a lot of what's happened the last 5 years is really because of basic science, clinical trial coming together. Precision medicine is where we are, particularly for advanced prostate cancer. And we're going to talk about some of those examples that are giving better ability to diagnose prostate cancer, but also giving us more effective treatment. A big breakthrough happened around 2015, 2016. Those of you that have dealt with medical oncology and breast cancer, this is kind of stock in trade, understanding germline mutations. We've known about this. Angelina Jolie and her discussion about inherited mutated tumors and things like this have been around a long time. It really wasn't until 2015 or 2016 that we finally figured out there was this connection between the same genes in breast cancer can be active when they're mutated in prostate cancer. So in ladies, BRCA1, when it's mutated, causes more aggressive breast cancer. In men, it turns out it's the BRCA2 is the more active mutated gene that causes advanced prostate cancer. And again, remember, I always like to say this when I talk to my medical students and residents, these genes do not cause cancer. We still do not know what causes prostate cancer beyond some of the things like family history. However, if you've got these mutated genes that are not working well to protect your genome, you tend to develop more aggressive cases of prostate cancer. And men who have germline mutations may actually not have a family history. It's very common to have a family history, but remember there's somatic testing and there's germline testing. And somatic testing is what's in the tumor. The germline is what's in every cell in the patient's body. So again, the original data showed that about 12% of men with advanced metastatic castration-resistant prostate cancer had germline mutations inherited from their parents and their grandparents. As time has gone on, that number is looking more like 20 to 25%. So the more you look for things, sometimes the more likely you are to find them. And if you look, men with localized disease, less than 5% will have a germline mutation, whereas men who present with metastatic castrate-resistant, most of them will have an inherited mutated germline mutation. So next generation sequencing, that's the big buzzword right now, whether you do it with a buccal smear, a blood test, or otherwise. The genes known as the HRR genes, the homologous recombinant gene pathway, the genes that allow our DNA to duplicate, if they're mutated, PARP inhibitors are very effective treatment for advanced prostate cancer. You've heard about Lynch syndrome. If a patient has genetic testing and they have these MHL1, MSH2 genes, pembrolizumab and immunotherapy can be an effective treatment. Other markers down there, tumor mutational burden and things like that, are things that you'll get on a gene report from Invitae or another company. Again, they give you an idea. These patients tend to respond well to immunotherapy. It's not great, not as great as the PARP inhibitors, but immunotherapy remains an option for them. So what about the HRR gene mutations? Again, we have many clinical trials out there that support this. So this one was the PROfound study that led to the approval of olaparib. Actually, way back in 2020, olaparib and rucaparib, two PARP inhibitors were approved within a week of each other. And again, here you look at the precision medicine impact. If you look at the right-hand panel is overall survival. You see an improvement in overall survival. Again, we're not curing anybody yet with prostate cancer. We might be able to send it into remission, but again, the important thing is if someone has just a PSA elevation, they're asymptomatic, not having any problems, we can sort of live with that. Again, these are patients who had mutated HRR genes, and again, you can see improvement in progression-free survival as well as interim survival. This is known as the Triton trial. This is the one that led to the approval of rucaparib as a PARP inhibitor back in 2020. So what's happened now is that we've gone to this triplet therapy over the last couple of years, such that combining now multiple agents is improving the outcome of metastatic castrate-resistant prostate cancer. So we now have, again, everything's ADT is the platform, but we now have olaparib with androgen pathway receptor blocker, niraparib, and talazoparib with enzalutamide, again, with or without HRR, BRCA1, BRCA mutations. Again, the approval to get these drugs from the specialty pharmacy or from insurance company usually requires that you get a germline or somatic testing to show that there is a mutated gene. So again, the PROPEL trial, the MAGNITUDE trial, the TALAPRO trial, again, these are cute names for these trials, but at the end of the day, they give us very strong data that particularly in patients with HRR mutations, mutated BRCA1, BRCA2, tend to do much better with castrate-resistant disease. If you look at the FDA approvals on the left-hand side, olaparib and rucaparib were the first two PARP inhibitors in prostate cancer that were approved. Pembrolizumab, which you know is like almost going to be, I think, put in, I think they have 18 different approvals right now. But if you look at things like microsatellite instability or tumor mutational burden, these are genetic characteristics. They're not HRR mutations, but they are sequences that you can identify when you do somatic or germline testing. Again, they tend to respond to pembrolizumab. The big thing at the bottom is the triplet therapy, niraparib and abi, olaparib and abi, or talazoparib and enzalutamide. Again, triplet therapy is becoming the standard of care for advanced prostate cancer. PET CT scans now picking up really amazing low levels of metastasis that we could never find before. So we're now getting into a new world order of what we believe is the earlier we treat advanced prostate cancer, the more likely there is to be long-term benefit. The caveat there is, as was mentioned by Grace, the side effect profile. And this is where you always have to come into this patient, physician, patient, provider, patient APP discussion about the side effect profile. So even though we're finding the disease earlier and we think earlier treatment is better, let's always remember everything we do is a double-edged sword and can have some significant side effect profile. Lastly, to wrap up on a biomarker, we talked about BRCA1, BRCA2. Think about PSMA scan as another marker because PSMA is required now for the use of lutetium, which is one of the really exciting therapeutic agents that we have in advanced prostate cancer, where you're now giving cytotoxic radionuclides to patients with advanced prostate cancer and attacking it wherever it is in the body. We have 2 trials right now, but you had to have a positive PSMA scan. One is the VISION trial. Again, we're seeing very, very prominent improvements in progression-free survival and in overall survival based on the VISION trial. Same thing for the PSMA other trials that have been done. Another trial, fairly new. If you look at this as a phase 3 PSMA-4 trial, this is taxane-naive metastatic castrate-resistant prostate cancer. Again, you get into the weeds a little bit with these clinical trials. What's the specific requirement for a man being on the clinical trial? But again, same thing, improvement. There was about a 60% reduction of progression with lutetium added versus an androgen receptor pathway blocker alone. So again, a lot of stuff going on. So we've talked about a lot of these systemic therapies for metastatic castrate-resistant prostate cancer. It's a little bit overwhelming when you look at it, but again, I encourage everybody to get the NCCN guidelines and use them. And you're going to find a lot of it is dealer's choice. You're not going to see a lot of difference between darolutamide and apalutamide and enzalutamide and abiraterone. And a lot of you may be in care environments where some of these drugs are approved. Some of them are a little bit more difficult to get approved. But again, we have an amazing opportunity here with metastatic castrate-resistant prostate cancer. Another trial out there, again, cute name, a SPLASH trial. This is who had patients with PSMA positive metastatic castrate-resistant prostate cancer who had failed an androgen receptor pathway blocker like abiraterone or enzalutamide. So we have one more case here that Grace is going to wrap up with.
So unfortunately, Mr. Jones went on to develop rising PSA on a combo of abiraterone, prednisone, and ADT. His PET scan is now showing increase in the size and number of his bone lesions of more than 5. He previously had the germline genetic test that showed a BRCA mutation. What are you going to do at this point? Are you going to start enzalutamide, olaparib, docetaxel, or pembrolizumab? So for Mr. Jones, actually the best agent to use at this time, knowing that he has a BRCA mutation, is the addition of olaparib. It has been found to be superior in the setting of BRCA mutation compared to these other agents. Again, pembro is used for mismatch repair gene deficiency, and we don't have that information for him. So what we need to know about this PARP-E or PARP inhibitors is that they have been associated with certain degrees of cytopenia, so supportive care with transfusions might be needed, as well as dose modifications. Fatigue also has been associated with them. It can be more severe, though, with your androgen receptor pathway inhibitors, so they're not as problematic as your RPs. And there's a very small risk, about a 1% risk of developing MDS or AML, leukemia or myelodysplastic syndrome for this population, so monitor your CBCs. For lutetium PSMA, typically well-tolerated, low-grade adverse events have been found with them. Fatigue can happen too, so supportive care is important. Also cytopenia, so monitor your count. Serostomia, make sure you're supporting them with these treatments. And radiation safety, so advise them to hydrate very well and to void frequently to protect the kidneys. These are some of the other side effects that we have seen with the use of these agents. So be careful with your older population. On average, metastatic cancer patients tend to have older age, so they tend to have more conditions that are coexisting too. Make sure you're validating their functional status using tools that have been validated before. Old does not always equal to frail. And again, control of cardiovascular disease or risk factors is very important. And manage the cytopenias whenever they arise. Leukopenia has been associated with up to 40% incidence in the use of lutetium, and thrombocytopenia up to 70% of patients. But again, usually milder cases, and patients are typically asymptomatic. For bone mets, you want to prevent skeletal-related events by using these medications that would promote their bone strength. Importance of multidisciplinary collaboration. There's many definitions that exist across many tumor types. Sometimes you have real clinical teams that are multidisciplinary. I know in my practice we have social work, psychology, palliative care embedded within the medical oncology practice, and all the other subspecialties are just floors away from us. There are care pathways now being used. Dr. Gomella talked about the NCCN guidelines. I know other healthcare systems have been using pathways too. The VA has also created their own pathway. So there are a lot of algorithms that are being utilized to manage these patients more appropriately and precisely. Tumor board recommendations are very crucial. Interdisciplinary management is very, very important for these patients. And usually the board would recommend treatment planning to the teams that are involved in the patient care. Your core team members are here, and essential support services. Make sure not only you, but your patient and their caregiver are aware of the resources available to them. You want to make sure that you develop and review a treatment plan with the patient. Shared decision-making is of utmost importance. Provide education to the patients and caregivers on what to watch out for. We may know them, but the patients, especially going on oral regimens, you're not going to see them every day. They need to know what to be watching out for and when to be calling you, and make sure they have your number. And make sure you have a good follow-up plan for monitoring. And I'm going to call Dr. Gomella back up to the stage for our concluding slide.
Great. Thanks, Grace, for that summary. So again, I think it's very important, and I think we've stressed over and over again, the real importance of the team, particularly the nursing staff, the APPs, more and more involved with the treatment of patients with all stages of prostate cancer, but most critical now with all of these therapeutic agents that we have available for advanced prostate cancer, a lot of hand-holding is necessary. One thing that I've learned over the years, if you warn patients about hot flashes, they're more likely to deal with them, as opposed to the man you don't warn about having a hot flash with ADT, who has a lot more problems with. So again, a lot of patient counseling is very important, and the team approach that Grace has mentioned. So again, it's been an explosion of available treatments for advanced prostate cancer statement. But what's happening, I like to say it's a shift to the left. Everything that we use now for advanced prostate cancer is moving earlier and earlier and earlier in disease. Again, to me, one of the most interesting trials you're going to be hearing more about is the lutectomy trial, where patients are getting Pluvitco before radical prostatectomy and seeing amazing local and systemic effects from it. So keep your eyes on that. Clinical trials are quite robust. There's a lot of them to keep track of. I actually have a little side project where I keep the cute names of all these projects out there. I'm up to about 256 different names. One day I'm going to write a telephone book on all the different trials, and you can look at the trial's name and say what the trial was and what the results were. So there's really a lot going on in our field. A lot of being invested from a pharmaceutical standpoint. But again, the bottom line and the reason we're here today is really reinforce the multidisciplinary approach to give the patient the best long-term outcome. So again, thank you all for letting us be here. We appreciate the opportunity for SUNA, for Plexus, and of course the sponsors who make all of this great stuff possible for making the meeting happen today. So again, thank you, and thank you, Grace, for the nice overview comments.
All right, so let's talk a little bit about next week. Couple things. If you watch, there's a survey coming out. It's going to be available on our website too. I'd like to know what you guys are thinking of the show and maybe some ideas that you might have to kind of improve the show. So there is a survey I'm putting out. Anyway, you can get it from our website. It's going to go out on the, if you get our email that comes out every week, it'll be on that. I also included something in the EuroConnect for SUNA members that watch that. So that'll lead us to what next week's episode's all about.
This year has been a remarkable year for urology nursing, patient care, and innovation. On this special episode of UroNurse, we take a comprehensive look back at the highlights and look forward to what next year may bring. Join Vic as he explores the most important advances in urology care, clinical updates, and patient-centered strategies that define this year. Whether you're a clinician, researcher, or patient advocate, this episode is your essential guide to understanding the milestones of 2025 and preparing for the opportunities and challenges ahead. Join us on January 10th at 9 a.m. Central Time to learn more.
So yeah, join us next week. We're going to go over what the statistics are looking like, the analytics from the show. Kind of think it's interesting to find out how well UroNurse is doing and continue to do. But more importantly, again, we're going to go over that survey. So fill that out if you get a chance. Should only take you a couple minutes, but that'll give us some ideas on what we want to do going forward into the future, because I plan to be around. Hopefully you'll plan to stay around as are fans of the show and keep watching. Hey, have a great rest of your day and welcome to 2026. We look forward to seeing you in the future. And that's it.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.